Okay. Good evening, everyone. So I just hope I'm visible and audible, right? So as we said, we are going to start discussing questions of week 2 also today itself. So coming to first question, and these are all very basic questions. You should know these questions for your upcoming NEET exam, for your inicet exam, or even if you are an FMG student, these are very basic questions. All of you should know these questions. So question number 1, we have a pregnant client who is making her first antenatal visit at 32 weeks, right, of pregnancy. She has previous history of stillbirth at 39 weeks 2 years back. Okay, so 2 years back she has history of stillbirth. She has twin daughters 3 years ago at 36 weeks, and she has history of ectopic 5 years back. Her obstetrical score is, so tell me, what is her obstetrical score? What is her gravida? What do you mean by gravida? Gravida is the number of time a female conceives, including this present pregnancy, right? So she has history of ectopic, she has history of twins, she has history of stillbirth, and this is her 4th pregnancy. This is the 4th time she has conceived, right? So tell me, what is her gravida? She will be gravida 4, right? Now, when we are talking about G4, P1 plus 2 plus 1 plus 2, what does that mean? That means there are 4 numbers which are written in front of parity. Now, if there are 4 numbers which are written, that means after gravida, if 4 numbers are written, that means it is a GT-PAL score which they are talking about. There is one system which is called as G-PAL system and the other one GT-PAL system. Now in GT-PAL system, after gravida 4 numbers will be written, right? And over here we can see after gravida 4 numbers. After gravida, then gravida is 4, and after that 4 numbers are written. That means this is a GT-PAL system which is being followed, right? Now in GT-PAL system, G stands for gravida, T for number of previous pregnancies which were term, and term pregnancies means pregnancies more than 37 weeks. P stands for number of previous preterm pregnancies from 20 weeks to 36 weeks plus 6 days. A stands for number of pregnancy losses which are happening at less than 20 weeks, which includes ectopic, which includes molar pregnancy. And L stands for number of living children at present, right? So number of living children at present is L, what L stands for. So if we use this system over here, so number of term pregnancies. So previously, how many term pregnancies she had? She had a stillbirth at 39 weeks, and that will be counted in term pregnancies. So 1 term pregnancy she had. Number of preterm deliveries which she had twin daughters who were born at 36 weeks, and that's a preterm. Twin pregnancy will be taken as a single conception, so it will be counted as 1. Then number of abortions. Whether we say number of abortions, whether we say number of abortions or number of ectopic pregnancies or molar pregnancies, any pregnancy loss which is happening at less than 20 weeks, right? So she has history of 1 ectopic which will be counted in abortions. Now comes number of living children which she has. I can see so many answers over here that I'm really confused what has happened to all of you. Now, number of living children. So, stillbirth will not come in living children. How many living children she has? She has twin daughters, right? So, 2 living children at present. Right? I don't know why you people are confused. So, I think maybe you are confused because this L you are thinking. See, L is not live births. It is number of living children at present, right? Stillbirth will not come in number of living children at present. Rather, it will not come in live birth also, right? So if she has twin daughters, right? So here the number of living children will be 2. It is only in L when we are talking about number of living children that you count twin as 2. Right? So this is G4 P1 plus 1 plus 1 plus 2. Are you understanding? This is GT-PAL system. Right? Please do not confuse. This is a very, very basic MCQ. Now, why we get confused is because of the G-PAL system. In G-PAL system, there will be a number written in front of gravida, and after parity, just 3 alphabet numbers will be written. Here, this P stands for parity. Right? This P stands for parity, and what do you understand by parity? Parity means number of previous pregnancies which have gone beyond the period of viability. And period of viability in India is 28 weeks. Now, A stands for number of abortions. Number of abortions means number of pregnancy losses at less than 20 weeks. And L stands for number of living children. Now, G-PAL system is not a very good system. Why? Because parity means number of pregnancies which are happening after 28 weeks, right? So, previous pregnancies which had gone beyond 28 weeks. Abortion means previous pregnancies which ended at less than 20 weeks. So, suppose there is a female in whom a pregnancy loss happened at 24 weeks in the previous pregnancy. Where do we count it? We can't count it in parity. We can't count it in abortions. That is why G-PAL system is not a good system. GT-PAL system is a good system. And over here, the answer is option B. Right? Clear to all of you? Okay. Question number 2. A client tells the junior resident on duty that her LMP was 25th July 2021. What is the estimated date of delivery? What is the estimated date of delivery? Option A, 1st April 2022. Option B, 2nd April 2022. Option C, 1st May 2022. And option D, 2nd May 2022. Tell me. What's your answer here? A, D, B, B, D, A, B. I am surprised that in basic MCQs I am getting so many different answers. I was thinking I'm going to get unanimously all of you would be knowing these MCQs. Rather, when I was writing these MCQs here, I was thinking that maybe I'm a little silly to write so easy questions here. Okay. Just remember basic things. Basic things you know, and that is Negley's rule or Negley's formula you have to put over here. But how do you apply Negley's formula? This is not any rocket science. Just remember this much. See, Negley's formula is to the first day of the last menstrual period, you have to add 7 days plus 9 months, right? Now, whether you add 9 months first and then 7 days, or whether you add 7 days first and then 9 months, ideally the answer should come the same, right? But please remember that sometimes in a rush, sometimes when we are in a hurry, we make very common mistakes, and to avoid this mistake, please remember that whenever you are applying Negley's rule to a LMP, and that LMP is beyond 22nd of that month. So, if any LMP is given to you which is beyond 22nd, so it could be 22nd May, it could be 24th May, it could be 23rd July, it could be 27th July, whenever any LMP is given beyond 22nd, to avoid mistakes, you should always add 7 days first and then 9 months. Then you are going to avoid very common mistakes. For example, just let me show you this with an example. So over here, this is 25th July, right? Now, I am telling you whenever LMP is given, beyond 22nd of any month, first add 7 days. So this is 25th, that means it is beyond 22nd. So I have to first add 7. So to 25th of July, when you add 7, 26th July, 27th July, 28th July, 29th July, 30th July, 31st July, 1st August. 1st August, right? So to 25th of July, when I have added 7, I have come on 1st August. 26, 27, 28, 29, 30th, 31st and 1st. Clear to all of you? Right? Now to this, I will add 9 months. Right? So now add 9 months to 1st of August. August, September, October, November, December, Jan, Feb, March, April, May. Right? So you are coming to 1st May 2022. Are you understanding? Suppose you didn't do this. Suppose you added 9 months first. Then what mistake you would have done? Then the mistake which you would have done is you would have said that the answer is April. Your EDD would have come in April because to July you would have added 9 months. So August, September, October, November, December, Jan, Feb, March, April. Then you would have said the answer EDD in April rather than in May. So please make it your habit that whenever you are asked to calculate EDD and the LMP is beyond 22nd of any month, first add 7 days and then 9 months to avoid any confusion. Yes, you can minus 3 months also. But then I always find that you people tend to make more mistakes when you have to count backwards rather than count forwards. So I am not saying that if you subtract 3 months, that's wrong. But it's always easier to go anti-grade rather than retrograde. Even I in my OPD when I'm sitting, I count it like this rather than going 3 months back. Right? Clear? Okay. Some find it easier to calculate backwards. I find it easier to calculate forwards, and that avoids any confusions, that avoids any mistakes. Clear? Okay, all of you. So over here, what is the answer? Your answer is 1st May 2022. Coming to question number 3. You are called to evaluate the heart of a 19-year-old primea gravida at term. Now, just one thing. In the gravida and parity question, I just want all of you to understand one thing. Suppose this question would have asked you about GPAL system. Right? Suppose this question was on GPAL. Right? It is not GTPAL. I am asking you GPAL. So please tell me her obstetrical score in GPAL. What would this lady's obstetrical score be in GPAL? I am not giving you options. You will have to just tell me the answer. What is her obstetrical score as per GPAL? Gravida will be 4 only, right? This is the 4th time she has conceived. Right? Now, parity. Tell me what is her parity. I am waiting for all of you to answer. What is her parity? I can see so many answers with respect to parity. Some people are saying parity is 3, some are saying parity is 2, some are saying parity is 1. And that is why I have come back to this question over here. What is parity? Just now I told you parity is the number of previous pregnancies. Please, it is the number of previous pregnancies. You never count present pregnancy in parity. So, number of previous pregnancies which have gone beyond the period of viability. That's one thing. Second thing you have to remember in parity is, in parity, twin pregnancy will be counted as one. It is a single conception, right? So, in this case, she had stillbirth at 39 weeks. So, that is one pregnancy, previous pregnancy which went beyond the period of viability. And then she had twin daughters who were born at 36 weeks. So, this is second conception which went beyond the period of viability. Ectopic will end obviously before the period of viability. So, ectopic will not be counted in parity. So, she will be G4P2. Presently, she is 32 weeks pregnant, but present pregnancy is not counted in parity. Are you understanding, all of you? So, G4P2, abortions. Number of abortions, 1. Number of living children, 2. So, G4P2A1L2. So, G4P2 plus 1 plus 2. Please, all of you who are writing parity 3, you are not right. Twin pregnancy will not be counted as double parity. It is counted as a single conception. Only in living children, twins is counted as, number of children's. You are going to count it as 2. Otherwise, in parity, twins is counted as a single conception. Present pregnancy is not counted in parity, right? So, according to GPAL, she is G4P2 plus 1 plus 2, right? This was GTPAL. So, in GTPAL, she was, just now I told you, in GTPAL, I think, what was the answer? Option B, right? Term pregnancy was 1, then preterm was also 1 abortion and 2 live births. Are you understanding? GTPAL, beta GTPAL में G is the number of time she has conceived including this pregnancy, that is gravida. T stands for number of previous term pregnancies. P stands for number of previous preterm deliveries. There P is not parity. GTPAL में P is not parity. P is number of preterm. A is abortion and L is living children. Abhijit Kanojia, have you understood this? Yes, this is GTPAL. In GPAL, P is parity. And what is parity? I have just now told you. Clear to all of you? Yes? Okay. Coming to question number 3. You are called to evaluate the heart of a 19-year-old primary gravida at term. Listening carefully, you determine that there is persistent split S1, normal S2, S3 can be easily audible with an ejection systolic murmur of grade 2/6 during inspiration. The murmur is greater during inspiration. You immediately recognize which of the following. Option A, presence of S3 is abnormal. Presence of ejection systolic murmur is unusual at term. Presence of both S3 and ejection systolic murmur is a significant abnormality. All findings are normal changes in pregnancy. Tell me. All of you say that this is normal? Yes. All these findings are normal findings in pregnancy in a heart patient. So, over here in the cardiovascular changes which are seen in pregnancy, BP decreases during pregnancy. Why blood pressure decreases? Because progesterone is a smooth muscle relaxant. So, there is a decrease in diastolic BP, decrease in systolic BP, decrease in mean arterial pressure, right? JVP remains normal in pregnancy. S1 is loud, S2 is normal, and S3, which is not easily heard during pregnancy, it is easily heard. Ejection systolic murmur less than grade 3/6 is absolutely normal during pregnancy, right? Now, femoral venous pressure. What happens to femoral venous pressure in pregnancy? Femoral venous pressure increases in pregnancy. What happens to cardiac output? Cardiac output also increases in pregnancy, right? In pregnancy, when is cardiac output maximum? In pregnancy, cardiac output is maximum between 28 to 32 weeks. Better answer is 32 weeks. But overall, if I ask you when is cardiac output normal, overall maximum, when is cardiac output maximum? Overall cardiac output is maximum at in the second stage of labor. First is immediately after delivery. Immediately after delivery, cardiac output is maximum, followed by second stage of labor, followed by late first stage of labor, that is the active phase of labor, and then 28 to 32 weeks of pregnancy, right? Now, if I ask you, when does cardiac output return to normal after delivery? When does cardiac output return to normal after delivery? So, cardiac output, it becomes normal 10 weeks after delivery. Right? So, cardiac output is normal 10 days after delivery. It's not 10 weeks, it's 10 days after delivery. Cardiac output returns to normal 10 days after delivery, right? Then, precisely it is 10 days. Precisely 10 days after delivery, cardiac output becomes normal, right? Now tell me that what are the findings which tell you that there is a patient has got heart disease, a pregnant female has heart disease. What are the findings which are going to tell you that? So if a pregnant female is having cyanosis, if a pregnant female is having clubbing, if she is having hemoptysis, if she is having PND, if she is having orthopnea, if she is having persistent dyspnea, persistently worsening dyspnea, which is progressive dyspnea, right? Or if she has S2, which is loud, right? And the split is prominent. If you are getting S4, if you are getting ejection systolic murmur, which is more than grade 3 by 6, more than equal to grade 3 by 6, right? If you are getting presence of a diastolic murmur, if JVP is raised, all these are findings which are going to tell you that a pregnant female has got heart disease in pregnancy, right? But these findings which were given to you, they were absolutely normal. So in heart disease chapter, very, very important is what are the maternal adaptations of the cardiovascular system during pregnancy. That's very, very important, number one. Second thing which is important is anticoagulation in pregnancy. So please read this question number 4. A 29-year-old G2P1L1, a known case of rheumatic heart disease with valve replacement at 26 weeks of gestational age, visits her obstetrician. She is on warfarin therapy and her PT-INR is 2. What, according to you, would the obstetrician have advised her regarding her anticoagulation? Right, so patient is on warfarin. Patient had undergone valve replacement and she's coming to you at 26 weeks of pregnancy. Her PT-INR is 2. So what, according to you, would the obstetrician have advised her regarding anticoagulation? Option A, continue oral anticoagulation till she goes into labor. Option B, continue oral anticoagulant till 36 weeks and then switch to low molecular weight heparin. Option C, continue oral anticoagulant till 36 weeks and then switch to unfractionated heparin. And option D, give vitamin K immediately as her PT-INR is raised. So what do you think has the obstetrician advised her? Now, as far as anticoagulation in pregnancy is concerned, one question on anticoagulation was asked in the last year NEET PG and this topic becomes very, very important. I'm going to give you some of the few important things which you need to know on anticoagulation. Please remember, if they ask you what is the drug of choice for anticoagulation in a non-pregnant female, right? And the patient has undergone bioprosthetic valve replacement. So if patient has undergone bioprosthetic valve replacement and she is a non-pregnant female, what is the anticoagulation of choice? What is the anticoagulation of choice? If there has been a bioprosthetic valve replacement, in bioprosthetic valve replacement patients, in a non-pregnant female, tell me what is the anticoagulation of choice? Bioprosthetic valve replacement. So for bioprosthetic valve replacement in a non-pregnant female, the anticoagulant of choice is neither warfarin nor heparin, it is aspirin. Right? If there has been a mechanical valve replacement, then the answer is warfarin. Right? Now, as far as anticoagulation in a pregnant female is concerned, I will tell you the different period of time, period of gestation and the anticoagulation of choice. But please remember that the European Society of Cardiology in 2021, they gave new guidelines, and according to these new guidelines, aspirin plus anticoagulants should not be used together in valve replacement patients. The American Heart Association guidelines said that aspirin and anticoagulant can be used together. But these are older ones. The latest European Society guidelines say that in a patient, pregnant female with valve replacement, you should not be using aspirin and anticoagulant together, right? Together in patients of valve replacement, right? So in valve replacement patients, you are not going to use both of them together, right? Now these are the flow charts, these are the tables which I had shared with you once these guidelines had come. I had shared with you on my Instagram handle, and I had told you various advantages and disadvantages of all anticoagulants. So when we compare warfarin and heparin, the advantage of warfarin is it is a stronger anticoagulant, and all of you know that pregnancy is a hypercoagulable state. But the disadvantage of warfarin is it can cross the placenta and it can lead to chondrodysplasia punctata. It can lead to a condition similar to that, right? Now, heparin. When we talk about heparin, the important thing is it does not cross the placenta. So that's the advantage. So it will not lead to congenital malformations. But the problem with heparin is it is a weak anticoagulant, and pregnancy is a hypercoagulable state. So we need a stronger anticoagulant, right? Now, when we talk about heparin, we have two things: low molecular weight heparin and unfractionated heparin. Now let us see the points related to low molecular weight heparin and unfractionated heparin. Low molecular weight heparin, the route of administration is subcutaneous. The disadvantage is it has a longer duration of action. So if I am using low molecular weight heparin very near to labor, there are chances of PPH, right? So very near to labor, I will not use low molecular weight heparin. Now when you are using low molecular weight heparin, you monitor factor 10A and your target is between 0.8 to 1.2, right? That is your target factor 10A level, right? Now, as far as unfractionated heparin is concerned, the route of administration is IV. So, whenever we say that we are using heparin in pregnancy for valve replacement, we prefer low molecular weight heparin because low molecular weight heparin is given subcutaneously, so it can be self-administered. Whereas for unfractionated heparin, it has to be given IV. Because it has to be given IV, the patient needs to be admitted. right? It cannot be self-administered. Disadvantage of unfractionated heparin is because it has to be given IV, it can lead to infection of the IV lines, osteoporosis, and there are increased chances of heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia. The advantage of unfractionated heparin is it has a shorter duration of action, and whenever you are using unfractionated heparin you have to measure APTT, right? For low molecular weight heparin you measure factor 10A, and for unfractionated heparin you measure APTT, and it should be 2 times the control value, right? Now, whenever you are giving warfarin, you have to monitor PT-INR, and your target is between 2 to 3, right? Now, keeping these things in mind, at different period of gestation, we use different anticoagulants in pregnancy. So, up till 12 weeks, in the first trimester, when there is a mechanical valve replacement, up till 12 weeks, the first choice drug which I'm going to use will be low molecular weight heparin. Why? Because it cannot cross the placenta, and this is the period of organogenesis, right? So at this time, I am not going to give her warfarin, except, now there is a very, very important exception which they have added, except if the dose of warfarin which the patient is using is less than 5 milligrams per day. So if before pregnancy she was using warfarin and the dose of warfarin was less than 5 milligrams per day, then during pregnancy also in the first 12 weeks I may continue with warfarin, but the dose should be less than 5 milligrams. Overall, in this period, the best choice drug is heparin, and which heparin? Low molecular weight heparin. If low molecular weight heparin is not given, then I give unfractionated heparin. But my drug of choice up till 12 weeks is low molecular weight heparin, right? Now, at 12 weeks, I am going to shift the patient to warfarin. So now at 12 weeks, I will shift her to warfarin, and till 36 weeks, I will keep on using warfarin because warfarin is a stronger anticoagulant. Now again at 36 weeks, from warfarin, I will shift her to low molecular weight heparin. Why? Because near term, I am not going to use a strong anticoagulant. After 36 weeks, patient may go into labor anytime, and I do not want the patient to be on a strong anticoagulant when she goes into labor. So I have to switch to a weaker anticoagulant, and between low molecular weight heparin and unfractionated heparin, I am going to choose low molecular weight heparin. Right? Now, 3 days before delivery or 1 week before delivery, right? Ideally, it should be 1 week before her EDD or at least 3 days before her EDD. From low molecular weight heparin, I will shift her to unfractionated heparin. Why? Because unfractionated heparin has a shorter duration of action, right? So now on the day of delivery, that is, you have to stop all anticoagulants. On her day of EDD, you are going to stop all anticoagulants and you are going to restart anticoagulants 6 hours after vaginal delivery or 24 hours after cesarean section. Now, when you are restarting, again you are going to restart with heparin. Right? And after 4th to 5th day, so ideally on 5th day, we give her warfarin. So now I am going to restart with heparin, and from 5th day onwards, I will add warfarin. And once I have added warfarin, I will wait for PT-INR to reach up to 2 to 3, and then I will withdraw heparin. Right? So that is the entire anticoagulation which has to be done. It's not my, generally I post updates on Instagram more frequently than on the Telegram group, and my Instagram handle is Dr. Sakshi Arora Hans, right? Have you understood this? So these are all the updates which I have already given you. I have also shared with you the clinical cases and their management. Now suppose your patient is on warfarin at the time of delivery. So on her EDD, see, I am telling you, you are going to shift your patient to heparin at 36 weeks. Now suppose patient did not come at 36 weeks to you, right? She comes very near to her EDD. Now what are you going to do? Now, if patient has come very near to her EDD, she did not come at 36 weeks to you. So, obviously, you cannot put her on heparin if she didn't come to you at 36 weeks. Now, in that case, I am going to do cesarean section. Why? See, warfarin is a very strong anticoagulant and warfarin crosses the placenta also. So, if a patient is on warfarin at the time of labor, right, if patient is on warfarin very near to her EDD, now in this case, if patient is, if I make her undergo vaginal delivery, what is going to happen? See, there are two risks. Because it is a strong anticoagulant, there are chances of PPH in the mother, right? Number two, when the patient is undergoing vaginal delivery, because warfarin crosses the placenta and it reaches the fetal circulation as well. So when the head of the baby is passing through the mother's birth canal, because of the pressure of vaginal delivery, there are increased chances of intracranial hemorrhage, right? Now, if I want to reduce these risks, see, the risk of PPH will still be there when I do a cesarean section. But the risk of intracranial hemorrhage in the baby will not be there when I do a cesarean section, right? So, if the patient doesn't come to you at 36 weeks, patient comes to you at the time of delivery and patient is on warfarin, then in that case, you have to do cesarean section. But like you are asking me that, ma'am, what if patient is coming at the time of labor? Now, if patient is coming at the time of labor, she is already dilated. Now, what to do? Now, I am going to stop warfarin. I am going to give vitamin K to the mother, and after delivery I am going to give vitamin K to the newborn baby also, because already patient is dilated. Now I am not going to take her up for cesarean section. Whatever harm had to be done is already done. So give vitamin K to the mother, give vitamin K to the newborn, and because patient may go into PPH, so give fresh frozen plasma to the mother if patient goes into PPH, because we don't have any anticoagulant which acts against, we don't have any antagonist of warfarin, right? So if patient is already in labor, then then I'm going to give vitamin K to the mother. After delivery, I'm going to give vitamin K to the newborn, and I'm going to give fresh frozen plasma to the mother. Now suppose patient is on unfractionated heparin and patient goes into labor. I just now told you that on the day of delivery, you have to stop all anticoagulants, including unfractionated heparin. So if patient is on unfractionated IV heparin at the time of labor, then in that case do nothing. Just stop heparin and continue vaginal delivery, because unfractionated heparin has a very short duration of action, right? But on the other hand, if patient is on low molecular weight heparin and patient is in labor, then in that case stop heparin, give protamine. Protamine is an antagonist, and continue vaginal delivery. Clear? Clear to all of you? All these conditions, are they clear to all of you? Thank you so much, Varun, for posting all my updates in the Telegram channel as well. Right? Have you understood? And very frequently you keep on asking me this question that, ma'am, why do we do a cesarean section when patient is on warfarin? So I hope you've understood this, that we are doing cesarean section not to prevent PPH. We are doing cesarean section so that we can prevent intracranial hemorrhage in the baby. Right? In the newborn baby, we can prevent intracranial hemorrhage. That is why we are doing cesarean section. Clear? Okay. So in this case, patient has come at 26 weeks. Patient is on warfarin. Her PT-INR is 2, which is fine. It should be between 2 to 3. Now what are you going to advise her? So you are going to say continue oral anticoagulants till 36 weeks and then switch to low molecular weight heparin. Right? Okay. Now, this is a very, very new question, because I want all of you, because heart diseases the questions will be very simple, very, very theoretical. Anticoagulation is very important. Other than that, yes, one question which I also want to discuss is this question. Match the condition with typical heart disease seen in newborn. Now tell me, Lithium intake by mother during pregnancy. I hope all of you can see this slide. I'm just trying to increase the size so that you can see. Right, now see. You have to match the condition with the heart disease. So if mother has taken lithium during pregnancy, what heart disease is going to happen in the baby? If mother takes lithium, excellent. Lithium intake leads to Epstein anomaly. What happens in Epstein anomaly? There is regurgitation of the tricuspid valve. Right. Now in Down syndrome, if a baby has Down syndrome, this is not maternal condition, it is just condition and heart disease. So if there is Down syndrome in the baby, what heart disease do you get? Down syndrome में what heart disease do you get? Excellent. In Down syndrome babies, the typical heart disease which you get is endocardial cushion defects. Right? Okay. In Turner's syndrome, what do you get? If a baby has Turner's syndrome, what heart disease are you going to get in them? In Turner's syndrome, you are going to get bicuspid aortic valve. That is better answer than coarctation of aorta. That's a better answer. If you have bicuspid aortic valve, that is a more better answer for the heart disease which is seen in Turner syndrome than coarctation of aorta. What is the most specific heart disease in babies of overt diabetics? The most specific heart disease is transposition of great vessels. The most common heart disease is VSD. Now tell me, in Down syndrome, the most common one is endocardial cushion defect. Which is the second most common one? Which is the second most common one? In Down syndrome, most common is endocardial cushion defect. Which is the second most common? Second most common is ASD. Right? So endocardial cushion defect is more commonly associated with Down syndrome than ASD. Right? Okay. VSD is the most common heart disease which is seen in babies of overt diabetics. Right? ASD is the second most commonly associated with Down syndrome. Most commonly associated with Down syndrome is endocardial cushion defect. Right? Okay. So if you want, you can copy this. In rubella infection is one of those infections where you get heart disease in the baby. Right? None of the infections will have heart disease. They will not lead to heart disease in the baby. But rubella infection, in congenital rubella syndrome, you get heart disease. And which heart disease? You get patent ductus arteriosus. Right? Then in overt diabetics, the most common is VSD, most specific is TGA. In Down syndrome, most common is endocardial cushion defect followed by ASD. In Turner syndrome, it is bicuspid aortic valve followed by coarctation of aorta. If a mother takes lithium in pregnancy, you will get Epstein anomaly or tricuspid regurgitation. Clear to all of you? These are all important heart diseases which you have to remember, which you get in various conditions in OBS. Now question number 6. A 30-year-old primigravida at 10 weeks of pregnancy presents for her routine antenatal examination. So she is coming at 10 weeks of pregnancy. Her cardiovascular examination is normal and on CBC her hemoglobin is 6.4. Right, so she is having anemia. She is having 6.4 hemoglobin, which is severe anemia. On peripheral blood smear, there is microcytic hypochromic anemia. Nestrov test is negative. Best line of management is. So now you tell me, Patient is coming to you at 10 weeks of pregnancy and you did a CBC, and on CBC you are getting hemoglobin 6.4. Now, what is the best line of management? Cardiovascular examination is absolutely normal. What is the management? Some are saying B, maximum are saying B, some are saying A, some are saying D. So hematinics and oral iron therapy is more or less the same. So I'm putting oral iron therapy, iron sucrose, blood transfusion, no treatment. Let me put D as no treatment. But I'm telling you, D is not the right answer, right? So D, I had to just put in something, so I just put in hematinics. D is not the right answer. A, B or C, that is, you have to tell me. Oral iron therapy, sucrose or blood transfusion. Patient is coming to you at 10 weeks of pregnancy and her hemoglobin is 6.4. Okay, now quickly I'll take you through anemia, right? Now in anemia you have to remember physiological anemia and pathological anemia, that is anemia in pregnancy. Physiological anemia, it is due to hemodilution, right? Hemoglobin is always more than 11 gram percent. It is never less than 11 gram percent. And on peripheral blood smear, it is a normocytic, normochromic anemia, right? Whereas when we talk about anemia in pregnancy, that is pathological anemia, then pathological anemia, most common cause of pathological anemia is iron deficiency anemia, right? Here hemoglobin will be less than 11 gram percent, and iron deficiency anemia mein you are going to get a picture which is microcytic hypochromic anemia. Microcytic hypochromic anemia, right? Now anemia, when we say anemia in pregnancy, so that means we are talking about pathological anemia, and this pathological anemia, it can be mild, moderate or severe. Mild means hemoglobin between 10 to 10.9, moderate means hemoglobin between 7 to 9.9, and severe means hemoglobin, I'm writing it here, severe means hemoglobin less than 7 gram percent. Right? Now, in your patient, the hemoglobin is 6.4. That means your patient is having severe anemia, and this severe anemia is happening at 10 weeks. Right? Till here it is clear to all of you. Now, the algorithm which you have to follow for management of anemia in pregnancy is, if anemia is severe anemia, then you have to see whether anemia is between 5 to 6.9 or it is less than 5. So if hemoglobin is less than 5 at any gestational age, irrespective of the gestational age, answer is blood transfusion. But if hemoglobin is between 5 to 6.9 and if gestational age is less than 34 weeks, then you have to go for parenteral iron. If the gestational age is more than 34 weeks, you have to go for blood transfusion, right? So understand this, if hemoglobin is less than 5 at any age, any gestational age, blood transfusion. But if hemoglobin is between 5 to 6.9, then you have to see the gestational age, and if gestational age is less than 34, parenteral iron. If gestational age is more than 34, blood transfusion. This is an algorithm, right? Now, if your question talks about mild to moderate anemia, again look at the gestational age. If gestational age is more than 34, parenteral iron. If gestational age is less than 34, then oral iron, and oral iron how much? 2 tablets in a day. Right? Now, when you are giving Parenteral iron, the most common iron which you use is iron sucrose. Iron sucrose is the most common form of iron which you are using. Please remember that blood transfusion has to be done in all patients in whom hemoglobin is less than 5 gram percent at any gestational age. Number 2, if there are signs and symptoms of congestive heart failure. Number 3, if patient has thalassemia. In thalassemia, that is if Nestrov test is positive, that is a screening test for thalassemia, you do not give iron. In that case, you have to give blood transfusion. So these are the indications for giving blood transfusion. So now please do not come to the answer just now. Do not jump to the answer just now. This is the algorithm which you follow in your management of anemia in pregnancy generally. Now, the typical point over here is that the question says that patient has come to you at 10 weeks. Now, if patient is coming to you at 10 weeks, that is in first trimester. Now, what you do? Please remember, in first trimester, parenteral iron is not given. Parenteral iron is not given in first trimester. Obviously, if patient is having active bleeding, you have to give blood transfusion. So don't write that. Or a patient who's having active bleeding, you never give iron to them. That's very obvious. Understand what I am telling you now. Now, if patient is coming to you in first trimester, you are never going to give parenteral iron. So, whenever a patient comes to you with anemia in first trimester, what you do? You have to see whether hemoglobin is less than 5 or whether signs of heart failure are present. Now, if hemoglobin is less than 5 and if signs of heart failure are present, then just now I told you that if hemoglobin is less than 5 or if signs and symptoms of heart failure are present, you have to go for blood transfusion. But if hemoglobin is more than 5 or if signs and symptoms of heart failure are not present, in that case you have to give oral iron. We do not give parenteral iron in first trimester because in so many patients we see that parenteral iron, it can initiate uterine contractions, and in first trimester we do not want that to happen because it can result in abortions, right? So you do not give parenteral iron in first trimester. Clear to all of you? So over here, because patient has come to you in first trimester and because her hemoglobin is more than 5, there are no signs and symptoms of heart failure. So over here, our answer will be oral iron therapy. Clear? Right? Rajoshi, we do not start oral iron before 12 weeks. That is the prophylactically jo we see. Please understand, you have two cases. One is a female. Suppose there is a pregnant female and this pregnant female at 10 weeks, her hemoglobin is 11.5, right? That means she has no anemia. Now in this patient, I have to give prophylactic iron, right, which is as per the Anemia Mukt Bharat program. And according to Anemia Mukt Bharat program, when are you going to start oral iron? The prophylactic dose, you are going to give 60 milligrams of iron plus 500 micrograms of folic acid starting from 12 weeks, right? That is from the 4th month of pregnancy, right? Now, but if you have a pregnant female at 10 weeks and her hemoglobin is 9, now I am not giving her prophylactic. I have to give therapeutic treatment to her. And now I can start oral iron. Now I have to start oral iron now. Now I am not going to wait till 4th month to start to give her iron. She is having anemia just now. You are not giving to prevent anemia. You have to give this dose to treat her anemia. Are you understanding? Yes? Clear to all of you? And for treating anemia, how much iron you have to give? For treating anemia, you have to give 2 tablets per day. Right? From 4th month, you start the oral iron. If you are giving as per Anemia Mukt Bharat program. Right? But this is for treatment. And treatment you can start just now if she is having anemia. I hope everything is clear to all of you. Yes, okay. Coming to question number 7. Question number 7 says, a 29-year-old Caucasian primigravida is 20 weeks pregnant with twins. She found out today on her antenatal visit and ultrasound that she's carrying 2 boys, 2 male babies. Her ultrasound shows a single placenta and thick membrane separating the twins. The finding on USG which suggests dichorionicity is R. Right? Now tell me, the finding on ultrasound which suggests dichorionicity is or are? Number 1, same-sex fetus. Number 2, single placenta. Number 3, thick membranes separating. It is not separating the twins. Right? So A is 1 and 3, B is 2 and 3, C is 1, 2 and 3, D is only 3. I can see all of you answering. Very nice. And all of you are answering it correctly. That is only 3. So please remember a few very, very basic things. The basic things are that dizygotic twins and monozygotic twins, all of you know. Now dizygotic twins, they are always dichorionic, diamniotic. But monozygotic twins, if division is happening at less than 72 hours, that means if division is happening in morula stage, you get dichorionic diamniotic twins. If division happens between 4 to 8 days, that means in the blastocyst stage, then you get monochorionic diamniotic twins. If division is happening between 8 to 12 days, then you get monochorionic monoamniotic twins. And if division is happening at more than equal to 12 days, that means after the formation of embryonic twins, you get conjoined twins. Right? Now, if you have to draw dichorionic diamniotic twins, so these are dichorionic diamniotic twins. Right? So each twin will have their own chorion, own amnion. So that means the membranes which are separating the 2 twins, there are 4 layers of membranes which separate the 2 twins. In other words, the membrane separating the 2 twins is very thick. Right? If I have to draw monochorionic, that means single chorion, and now each twin has their own amnion and we have the twin in between like this. Now the number of layers of membranes which separate the twin is just 2. That means thin layer will be present. If I draw a layer, you will get a thin layer between the 2 twins. So if you are getting thick layer between 2 twins, it means dichorionic. If you are getting thin layer, it means monochorionic diamniotic. Now draw monochorionic monoamniotic. If you have to draw monochorionic monoamniotic. So both the twins are surrounded by a single chorion, single amnion, and then we have the twins. So there is no layer of membrane between the 2 twins. So this is how you draw monochorionic monoamniotic twins. And then you have conjoined twins. Right? Now, in case of monochorionic monoamniotic twins, because both the twins are in the same amniotic fluid. So one very important complication which you get over here specific to this is cord entanglement. right? And that is why in monochorionic monoamniotic twins, you have to deliver them by Cesarean section, and the time of delivery is between 32 to 34 weeks. Right? This is what you have to remember about monochorionic monoamniotic twins. So if they ask you what are the complications which are specific to monoamniotic twins, so complication which is specific to monoamniotic twins are two complications: cord entanglement and conjoined twins. Conjoined twin is also a complication of monoamniotic twins. If they ask you what is the most common variety of conjoined twins, best answer is paraphagus. If paraphagus is not given, then you are going to say thoracophagus. If paraphagus is in the option, you are going to mark it as paraphagus. In conjoined twins and in monochorionic monoamniotic twins, delivery is by Cesarean section. This is what you have to remember about these two conditions. Now let's talk about dichorionicity and monochorionicity. Now it's very important to differentiate between dichorionic and monochorionic twins, because like we have certain complications which are specific to monoamniotic twins, there are complications which are specific to monochorionic twins. The complications which are specific to monochorionic twins are twin-to-twin transfusion syndrome, twin anemia polycythemia sequence, right, and TRAP, twin reverse arterial perfusion. These are complications which are specific to monochorionic twins, and that is why whenever we have a twin pregnancy patient, it is very important for us to know whether we are dealing with dichorionic twins or monochorionic, because monochorionic will have bad prognosis and dichorionic will have good prognosis. Till here it is clear to you? Now as you can see from this flow chart, dichorionic twins can come from dizygotic twins, and dichorionic twins can also come from monozygotic. So whether the dichorionic twin is coming from dizygotic or monozygotic, that doesn't make any difference. Dichorionic hai to prognosis achhi hai. If you have a dichorionic twin, prognosis is good. Whether it is coming from dizygotic, whether it is coming from monozygotic, it doesn't matter. Right? Monochorionic is always going to come only and only from monozygotic. Monochorionic means that the twin is monozygotic. Right? Dichorionic doesn't mean that the twin is dizygotic. Dichorionic can come from dizygotic, dichorionic can come from monozygotic. Is this point clear to all of you? Now, what are the markers of dichorionicity on ultrasound? This is very, very important for your NEET as well as for your INI set exam. So, if you are getting two separate placentas, then that means 100% the twins are dichorionic. But please remember, a single placenta may mean monochorionic, it can also mean dichorionic. Why? Because it could be that there is less space. So there were two placentas of dichorionic twins which ultimately because of less space fused. So if you are getting a single placenta, you cannot comment that whether we are getting monochorionic or whether we are getting dichorionic. But if you have two placentas, it is 100% a case of dichorionic twins. Now, if you have got same-sex twins, now please understand, monozygotic twins will always have same sex. Dizygotic twins can have same sex or they can have opposite sex. Now, because dichorionic twins can be dizygotic, dichorionic twins can be monozygotic. So, dichorionic twins may have same sex or they may have opposite sex. But please remember, monochorionic twins will always have same sex. So what I am saying is, monochorionic twins will always have same sex because monochorionic are always monozygotic, and in monozygotic you always have same sex. Dichorionic twins, they can come from dizygotic, they can come from monozygotic. If they are coming from monozygotic, they will have same sex. If they are coming from dizygotic, they may have same sex, they may have opposite sex. In other words, if you are getting opposite sex, then you can be sure that they are dichorionic. If you are getting same sex, you cannot be sure whether it is dichorionic or monochorionic, right? So opposite sex twins also means dichorionicity. Third is twin peak sign or lambda sign. If you are getting a twin peak sign or lambda sign, that means you are dealing with dichorionic twins, right? So over here, this is dichorionic, diamniotic, dichorionic, diamniotic. And this over here is a placenta. I am making a single placenta just now, right? Two separate hai to 100% dichorionic hai. Single placenta hai, it could be dichorionic, it could be monochorionic. Now, because there is space between the two chorions, this placenta will come in between the chorion, and this is what is a twin peak sign. So if you can see placental tissue coming in between the two chorions, that is a twin peak sign or lambda sign. So if you are getting lambda sign or twin peak sign, that means it is dichorionic. If you are getting thick membranes between the twins, just now I told you, if you are getting thick membranes between the twins, how much thick? More than 2 millimeters thick, then it is dichorionic. Or if your question says 4 layers of membranes between the twins, then it is dichorionic, right? So the markers of dichorionicity are two separate placentas, opposite sex twins, thick membranes, 4 layers of membranes, or twin peak sign or lambda sign. Now, if they ask you what is the most common type of twins, most common type of twins are dichorionic, diamniotic, because most common are dizygotic. Dizygotic are 80% twins, monozygotic are just 20%. And dizygotic are always dichorionic, diamniotic. So the most common type of twin is dichorionic, diamniotic. If they ask you most common type of monozygotic twins, then it is monochorionic, diamniotic, right? Now, please remember 38, 36, 34. 38 weeks pe you have to terminate dichorionic, diamniotic twins. Right? Termination of pregnancy in dichorionic, diamniotic is done at 38 weeks. In monochorionic, diamniotic 36 weeks. And in monochorionic, monoamniotic 34 weeks. So 32 to 34, you can remember 34. So 38, 36, 34. Right? Monochorionic, monoamniotic twins always cesarean section. Clear? Okay. Now, come to the next question. Next question is, a G2P1 at 28 weeks with twin gestation undergoes ultrasonography. The sonogram indicates that both the fetuses are male and chorionicity is diamniotic, monochorionic. So you have monochorionic, diamniotic twins. Twin B is noted to have oligohydramnios. Twin B has oligohydramnios and has hydrops. On Doppler, middle cerebral artery's peak systolic velocity is 2 mom. Twin A has polyhydramnios. The Quintero stage is. I'll show you twin peak sign on ultrasound. Arush, I'll just show you that. So twin A has polyhydramnios, Quintero stages. Who's going to tell me Quintero stage? Option A, stage 2, option B, stage 3, option C, stage 4, and option D, stage 5. So you are saying option B. Some are saying option C. Okay. Read your question carefully. No. Who said that twin B decides the stage? No twin is going to decide the stage. The findings are going to decide the stage. Okay. So I think you all are making wild guesses. Some of you are definitely right, and if this is a something which you remember, that's commendable. all the Marrow subscribers, I have told you Quintero staging, and Quintero staging you have to remember because a previous question on NEET was asked on Quintero staging, right? So first, let's quickly talk about twin-to-twin transfusion syndrome. Now, twin-to-twin transfusion syndrome, the diagnosis is going to be made on ultrasound, and on ultrasound, if you have monochorionic diamniotic twins, and in one twin you have oligohydramnios and other twin has polyhydramnios, then you make the diagnosis of twin-to-twin transfusion syndrome. So monochorionic diamniotic twins, one twin with oligo, other twin with poly. Now please remember that in twin pregnancy, the best parameter to know about amniotic fluid is not amniotic fluid index. Best parameter for amniotic fluid in twin pregnancy is single largest vertical pocket. So if single largest vertical pocket is less than 2 centimeters, it is oligo. If it is more than equal to 8 centimeters, it is poly. Right? Now, in twin-to-twin transfusion syndrome, one of the twin will be a donor twin, other twin will be a recipient twin. Over here, A and B is not what it was there in the question. So, I'm not talking about A and B like this. Okay, so I'm just keeping it X and Y. Otherwise, you'll get confused. So, suppose X is the donor twin and Y is the recipient twin. So, donor twin will have oligohydramnios. In donor twin, hemoglobin will be less because it is giving blood, so there will be anemia. And whenever there is anemia, a typical thing is that on middle cerebral artery, the peak systolic velocity will be more than equal to 1.5 mom. So when a fetus has anemia, you have to check middle cerebral artery Doppler, and in anemic fetuses, peak systolic velocity of middle cerebral artery is more than 1.5 mom. Now, because in a donor twin, there is less blood flow, so there will be less blood available in the donor twin, so it can lead to renal failure, and because its heart is working harder, so there can be heart failure, right? Now, in case of polyhydramnia, in case of the recipient twin, there will be polyhydramnios, hemoglobin will be more because it is receiving blood, so there will be polycythemia. And when you will do peak systolic velocity of middle cerebral artery, the peak systolic velocity will be less than 0.8 mom, right? And because it is getting a lot of blood, so there can be congestive heart failure, and because of polycythemia, there can be thrombosis. Please remember, either of these twins can develop hydrops, right? Because ultimately heart can fail in any of these two twins. Donor twin can also have heart failure, and recipient twin can also have heart failure. Recipient twin may congestive heart failure. Donor twin may, because it has to work hard, so there can be heart failure. So hydrops can be seen either in donor twin or in recipient twin, right? Now, when we talk about Quintero staging, stage 1 means, and now see, this Quintero staging is also based on ultrasound. This is an ultrasound based staging, right? So in stage 1, one twin will have oligo, the other will have poly, and bladder of the oligo twin will be visible. Stage 2 means that now there is so much oligohydramnios that urine formation is not happening. There is no residual urine in the twin, which is the donor twin. So bladder of the oligo twin is not visible on ultrasound, makes it stage 2. Stage 3 means that now you will get Doppler abnormalities. That means when you will do peak systolic velocity of middle cerebral artery in the anemic twin, it will be more than 1.5 mom. In the polycythemic twin, it will be less than 0.8. Then stage 4 means if either one or both twin develops hydrops, that is stage 4. And stage 5 means if either one or both the twins die, then that is stage 5. Now, in the question which was given to you, one of the twins was developing hydrops. So the moment any of the twin develops hydrops, that means it is stage 4, right? So you had to concentrate on this word hydrops. Many of you were writing stage 3 because you were concentrating only on abnormal Doppler findings. If hydrops was not there, then it would have been stage 3. Clear? Because hydrops is there, so it is stage 4. Clear to all of you? Yes? What is the management of twin-to-twin transfusion syndrome? Fetoscopic laser ablation. Please remember, twin-to-twin transfusion syndrome is seen in monochorionic diamniotic twins rather than, it's more common in monochorionic diamniotic rather than monochorionic monoamniotic. Right? Clear to all of you? Yes? Coming to the next question. Next question is, a G2P1 diabetic female well controlled on insulin goes into spontaneous labor at 39 weeks of pregnancy. The head of the baby delivers, but there is delay in the shoulder of the baby by more than 5 minutes. All of the following steps are taken to help in delivery of the shoulder. Number 1, fundal pressure. Number 2, episiotomy. Number 3, flex the thighs against the abdomen. Number 4, emergency cesarean section. Tell, what steps are you going to take? Option A, 1 and 2. Option B, 1 and 4. Option C, 1 and 3. Option D, 2 and 3. So I can see all of you answering it as option D. So over here we are dealing with the case, and all of you are right, we are dealing with the case of shoulder dystocia. Shoulder dystocia means inability of the shoulders to deliver even after 1 minute of the delivery of the head. And whenever you have shoulder dystocia, you have to follow this stepwise management, which can be memorized by the acronym HELPER, where H stands for call for help, E stands for you have to give episiotomy and empty the bladder of the patient. L stands for the leg maneuver. What is leg maneuver? That is McRoberts maneuver, where you have to hyperflex the thighs against the abdomen. Please remember, when you are doing McRoberts maneuver, when you are hyperflexing the thighs against her abdomen, it leads to rotation of pubic symphysis in the cephalad direction, and that leads to straightening of the sacrum. So please remember that whenever you are doing McRoberts maneuver, it doesn't change the pelvic diameters. Pelvic diameters are not changed. There is straightening of the sacrum, and because there is straightening of the sacrum, there is more space. Because of the straightening of the sacrum, there is no increase in pelvic diameter. Pelvic diameters will not change when you go for McRoberts maneuver. The other question which they ask you is that what is the most common nerve which is damaged due to McRoberts maneuver? It leads to injury to lateral cutaneous nerve of the thigh, right? Meralgia parestheticus. So it leads to injury to lateral cutaneous nerve of the thigh. That is also very important question. Now, so H was call for help, then E was give episiotomy, empty the bladder, L was do the legs maneuver, which is McRoberts maneuver. Now, if by simply performing McRoberts maneuver the shoulders are not delivered, now P means give suprapubic pressure along with McRoberts. So over here, can you see suprapubic pressure is being given along with McRoberts, right? And please remember, fundal pressure is contraindicated. Suprapubic pressure is given along with McRoberts. Now, if you are giving only suprapubic pressure and you are not doing McRoberts, that is called as Rubin 1 maneuver, right? Then E stands for enter and rotate. Now you are going to take your hand, which are the rotational maneuvers. So you are going to take your hand inside and you are going to try to rotate the shoulders. One of this maneuver is Wood's corkscrew maneuver and Rubin 2 maneuver. So in Rubin 2 or Wood's corkscrew maneuvers, you are trying to rotate the shoulders, right? So take your hand inside and rotate the shoulders. So E stands for enter and rotate the shoulders, right? Wood's corkscrew, no details needed. Wood's corkscrew maneuvers and Rubin 2 maneuvers. Now then, if this is also not successful, then comes R. R means you have to remove the posterior arm forcefully. So try to deliver the posterior arm forcefully. Now when you are trying to deliver the posterior arm forcefully, you can fracture the arm of the baby, right? Then next R, the last R stands for ask the patient to roll over on all four limbs. And that is called as the knee hand position or the Gaskin's maneuver or the all four maneuver. And then try to deliver. That is roll the mother on all four limbs, Gaskin maneuver or the all four maneuver. And if everything fails, then the last option is Zavanelli's maneuver, in which you push the baby back into the uterus and then you go for Cesarean section, which is called as Zavanelli's maneuver. That leads to a lot of trauma to the baby as well as to the mother. Now, if the baby is dead, then one destructive procedure which you may do. Normally in present day OBS we do not do any destructive procedure, but if baby is dead, one destructive procedure which may do in shoulder dystocia is cledotomy. We can fracture the clavicle of the baby and then we can deliver the arm. There is no role of symphysiotomy. So this is the algorithm which you have to follow for management of shoulder dystocia. Clear? So fundal pressure, it is not given. Episiotomy is given. Flex the thighs against the abdomen, right. Emergency Cesarean section, wrong. So answer over here is option D, 2 and 3. Now, if they ask you what is the most common maternal complication of shoulder dystocia, it is PPH. If they ask you what is the most common neonatal or fetal complication, it is Erb's paralysis, that is brachial plexus injury. Right? Now, in this question, the risk factor for shoulder dystocia was that the mother had diabetes. And in diabetic patients, the baby will have macrosomia. Right? And this macrosomia can lead to shoulder dystocia. Clear to all of you? Yes, question number 9. Now this over here, I want all of you to see image B. What is image B showing to you? This is showing you turtle sign. What is turtle sign? That once the head of the baby is delivered and the shoulder dystocia happens, then the head tries to retract back into the perineum. So because the head is trying to go back into the perineum, that is what is shoulder dystocia. That is what is turtle sign in shoulder dystocia. Right? Okay, coming to question number 10. A primigravida female undergoes 2-hour OGTT at 12 weeks of pregnancy and her 2-hour PP value is 222 milligrams per DL. In such a patient, the next step in management is. Now over here, the 2-hour OGTT test she is undergoing at 12 weeks of pregnancy and her 2-hour PP value is 222 milligrams per DL. So what is the next step in management? Option A, start MNT alone for 2 weeks. Option B, start MNT and insulin. Option C, start MNT and metformin. Option D, do nothing and repeat the test at 24 to 28 weeks. So some of you are saying option B, some are saying D. Okay. Now, please remember that in India, we are following the DIPSI criteria, and as per the DIPSI guidelines, you have to do a screening in all pregnant females at the first antenatal visit. Right? So, whenever patient comes to you for the first antenatal visit, you are going to go for the screening test. Right? And that is the same. You go for a single test, and that is the test which I'm going to tell you. Single test I'm going to do in the first antenatal visit, and then again I'm going to repeat it at 24 to 28 weeks. Right, so that is what DIPSI guidelines say, that you have to test for diabetes in the first antenatal visit and plus again between 24 to 28 weeks. Now, how do you have to do the test? Irrespective of previous meals, no fasting is needed. Whenever a pregnant female comes to you for the first antenatal visit, you give her 75 grams of oral glucose and check her blood sugar levels after 2 hours. Right? So, because you are checking her blood sugar levels after 2 hours, this is also called as a 75 gram 2-hour OGTT, but the only thing is that I am not doing it in a fasting state. No fasting is needed. This is what DIPSI says, that you give her 75 grams of glucose irrespective of her previous meals, and after 2 hours check her blood sugar levels. Right? Now, if after 2 hours blood sugar levels are less than 140, that means she's normal. If the levels are between 140 to 200, that is a case of gestational diabetes, right? And gestational diabetes happens because of insulin resistance in pregnancy. And if her blood sugar levels are more than equal to 200, then she's a case of pre-gestational diabetes or overt diabetes. In other words, patient was diabetic before pregnancy also, and maybe she didn't know about it. Right? Now, so in our case, the blood sugar levels which are coming after 2 hours are 222 milligrams per dl, and 222 means that she is a case of overt diabetes. Right? So if her blood sugar is 222 milligrams per dl, we are talking about overt diabetes. Now, in overt diabetes, how do you manage? Now, whether it is gestational diabetes, whether it is overt diabetes, you have to do a weight counseling in both these category of patients. Number two, in both these category of patients, you have to give them diet modification, which is called as medical nutrition therapy. Right? Now, in case of overt diabetes, along with medical nutrition therapy, I will immediately start insulin. Right? But in case of gestational diabetes, I'm going to give just diet modification, that is MNT, for 2 weeks, and I'm going to aim that her fasting blood sugar should be less than 95 and her 2-hour PP value should be less than 120. Now, please remember, fasting blood sugar less than 95, 1-hour PP less than 140, 2-hour PP less than 120, then average capillary glucose less than 100, average capillary glucose less than 100, and HbA1c less than 6. This is my goal, that fasting blood sugar should be less than 95, 1-hour PP less than 140, 2-hour PP less than 120, right? Then average capillary glucose less than 100 and HbA1c less than 6 gram %. That is your goal, right? We aim at less than 6%, but we are okay if HbA1c is less than 6.5 also. Right? So even if it is less than 6.5, it is acceptable, but we aim that the better is that if HbA1c is less than equal to 6. Right? Clear to all of you? Now, if these goals are not met in 2 weeks, then we put the patient on insulin. The other thing is, if a gestational diabetic patient is non-compliant with insulin, then the alternative is metformin. But in case of overt diabetes, you never give metformin. The only treatment is insulin. Right? Clear to all of you? Now, along with this, in case of overt diabetes, because overt diabetes is a risk factor for PIH, you will also give aspirin. Why are you giving aspirin? To prevent preeclampsia from happening or PIH from happening. So this is how you manage an overt diabetic patient. The moment you diagnose that the patient has overt diabetes, weight counseling, medical nutrition therapy, start insulin immediately, never give metformin, and give aspirin also. Okay, now someone is asking DNA that what are the values 92 and 183 for. So just let me quickly clear 1 or 2 more doubts for you people, because these things are very oftenly asked. So just let me tell you how you are going to diagnose diabetes in pregnancy. Right. So just now I told you the DIPSI guidelines. Right. Now, how do you diagnose gestational diabetes as per ACOG and as per American Diabetes Association? So this is what you have to remember. American Diabetes Association, the criteria for overt diabetes is fasting blood sugar levels more than equal to 126, 2-hour OGTT or random blood sugar levels more than equal to 200 and HB1AC more than 6.5. So if fasting is more than equal to 126, 2-hour OGTT value or random blood sugar levels are more than equal to 200 or HbA1c more than equal to 6.5, that is a case of overt diabetes. In our question also, if we do not go by the DIPSI criteria, even if we go by American Diabetes Association criteria and we see 2-hour OGTT value, if it is more than 200 there, so we diagnose the patient as overt diabetes, right? Now, American Diabetes Association criteria and IADPSG criteria for gestational diabetes is the same. Now, both American Heart Association and IADPSG, what is IADPSG? International Association of Diabetes Pregnancy Study Group, right? That is International Association. DIPSI is an Indian guideline. IADPSG are international guidelines. So American Heart Association and the other international guidelines, they say that you should be checking for gestational diabetes between 24 to 28 weeks. Fasting stage, you have to first, the patient should be for overnight fasting. After overnight fasting, you are going to take the fasting blood sugar levels. Then you are going to give 75 grams glucose and then you are going to check 1-hour PP value and 2-hour PP value. DIPSI says that the test has to be done in the first antenatal visit, number 1. DIPSI says that no fasting is needed. In both DIPSI and international guidelines, you give 75 grams of glucose. In DIPSI, you have to check blood sugar levels only after 2 hours. In case of international guidelines, you have to take fasting blood sugar sample, you have to take 1-hour PP sample and 2-hour PP sample. And the international guidelines say that out of these 3 samples which you are collecting, if one or more than one value is abnormal, then that's a case of gestational diabetes. And what are those values? Fasting, the upper limit for fasting should be 92, 1-hour PP should be 180, upper limit, and 2-hour PP, upper limit is 153. So 92, 180, 153. Right? Clear? So have you understood? These are international guidelines. Those were the Indian guidelines which I was telling you. According to Indian guidelines, you have to do the test at first antenatal visit and then repeat between 24 to 28 weeks in all pregnant females. And if 2-hour PP value comes more than 140, it is gestational diabetes. More than 200, it is overt diabetes. Okay. Now, how are overt diabetes and PIH related? So, please remember that diabetes is a risk factor for PIH. If a patient has diabetes in pregnancy, then that is a risk factor for PIH. And all of you know, to prevent PIH, the drug which has to be given is aspirin. Right? Okay. Now, so now your question is saying her 2-hour OGTT value at 12 weeks, the 2-hour PP is 222 milligrams per DL. That means she's a case of overt diabetes. In overt diabetes, what is the management? In overt diabetes, management is MNT and insulin. So I'm going to start her MNT and insulin. Metformin is never used in overt diabetes and you never start just MNT in overt diabetes. MNT and insulin is the treatment. Harit, the go-to value is DIPSI. Wherever you have Indian guidelines, you have to go by the Indian guidelines, but you have to remember the international guidelines because there was a question in INI set where they had asked you about IADPSG criteria, right? So if you go to the recall session of NEET and INI set, everything, all the criteria, the ACOG criteria, the IADPSG criteria, and the DIPSI criteria I have explained in details, and these sessions are available on Marrow YouTube channel, the previous year recalls, right? Now we will also talk about the termination of pregnancy, in which condition when to terminate pregnancy in diabetes. That will come a little later. Now read this question over here. A 32-year-old G2P1 at 12 weeks of gestation comes for antenatal visit. 1 week earlier, she had some nausea, vomiting and headache for which she had consulted a physician. Her last time BP reading was 140 by 94 millimeters of mercury and 136 by 92 millimeters of mercury after 15 minutes. The physician had asked her to monitor her BP and consult a gynac. Today her BP is 150 by 100. Dipstick shows no proteinuria. What is the diagnosis? So patient is coming to you at, no, you cannot follow international guidelines. In India, we follow Indian guidelines and the Indian guidelines are the DIPSI guidelines. Right? So India may we follow DIPSI guidelines, but you have to be aware of the international guidelines as well. Okay, come now. So, what is the diagnosis? Chronic hypertension, gestational hypertension, mild preeclampsia, gestational hypertension with superimposed preeclampsia. I am getting various answers here. Most of you are saying A, some of you are saying B also. Okay, so please remember that whenever you have a patient of high BP in pregnancy, and what do you mean by high BP? High BP means either systolic BP is more than equal to 140 or diastolic BP is more than equal to 90 or both. So even if systolic is more than 140 and diastolic is suppose 86. So suppose a patient's BP is 142 by 86. Then also that will be called as hypertension. Or suppose her BP is 136 by 96. Then also it will be called as hypertension. Right? So if either systolic BP is more than equal to 140 or diastolic BP more than equal to 90 or both on 2 occasions 4 hours apart, that is what is defined as high BP in pregnancy. Now, whenever you have a question which says that there is high BP in pregnancy, look at the period of gestation. If period of gestation is less than 20 weeks and patient's BP is high, or suppose your question says that the BP is high or BP remains high after 12 weeks of pregnancy, after 12 weeks of delivery, sorry. So if your question is saying BP is high at less than 20 weeks of pregnancy, right? Or if your question says that BP remains high even after 12 weeks of delivery, then that means 100% it is a case of chronic hypertension in pregnancy. So this patient was hypertensive before conceiving. So that is why her BP is high at less than 20 weeks of pregnancy also, and her BP will remain high even after 12 weeks of delivery. But if your question says that the rise in BP is seen after 20 weeks of pregnancy, right? So now if your question says the rise in BP is seen after 20 weeks of pregnancy, that means we are talking about pregnancy-induced hypertension. And pregnancy-induced hypertension, it could be preeclampsia or it could be gestational hypertension. In preeclampsia, you are going to get proteinuria or you are going to get signs of end organ damage. So your question is going to say that on dipstick, proteinuria was more than equal to +2. Or your question will say that there was excretion of proteins more than equal to 0.3 grams in 24 hours, or protein is to creatinine ratio is more than equal to 0.3. Any of these three things your question is going to tell you whenever they have to talk about proteinuria. Dipstick more than equal to +2, protein excretion more than equal to 0.3 grams in 24 hours, or protein is to creatinine ratio more than equal to 0.3, or there will be signs of end organ damage. Now, then you say that you are dealing with a case of preeclampsia. If these are absent, then we say we are dealing with a case of gestational hypertension. Clear to all of you? Yes. Now, in preeclampsia, it could be mild preeclampsia or severe preeclampsia. Now, what is the criteria for severe preeclampsia? Criteria for severe preeclampsia is if BP is more than equal to 160 by 110, right? Or if signs of end organ damage are present. What are the signs of end organ damage? Liver enzymes increase to more than 2 times their normal values. Platelet count less than 1 lakh. Serum creatinine more than equal to 1.1. Pulmonary edema if it is present, or headache or visual disturbances if they are present. So if BP is more than 160 by 110, liver enzymes are raised to 2 times their normal values, platelet count less than 1 lakh, serum creatinine more than 1.1, pulmonary edema present, or headache or visual symptoms. If any of these things are present, then we say we are dealing with severe preeclampsia. Right? Please remember that Iugr, oliguria and severe proteinuria, they are findings in a patient of severe preeclampsia. They are not a diagnostic criteria. You do not diagnose severe preeclampsia based on Iugr. So Iugr will not tell you whether you are dealing with severe preeclampsia or mild preeclampsia. Oliguria will not tell you whether you are dealing with mild preeclampsia or severe preeclampsia. Severe proteinuria will not tell you whether you are dealing with mild preeclampsia or severe preeclampsia. These are the findings which are going to tell you that you are dealing with severe preeclampsia. Now, what is chronic hypertension with superimposed preeclampsia? Chronic hypertension with superimposed preeclampsia means if you have a known case of chronic hypertension and suddenly at 20 weeks your patient has, number one, uncontrollable BP. Uncontrollable BP, or suddenly your patient has proteinuria, new onset proteinuria, right? Or suddenly your patient starts showing signs of end organ damage. What are signs of end organ damage? From 2 to 6, whatever these findings are, these 2 to 6, these are signs of end organ damage. So patient is a known case of chronic hypertension and suddenly at 20 weeks a BP becomes uncontrollable, there is new onset proteinuria or signs of end organ damage. That means you are dealing with chronic hypertension with superimposed preeclampsia. So over here your patient is 12 weeks pregnant. And in 12-week pregnant patient, you are getting BP which is 140 by 94 once, then after 15 minutes 136 by 92, and then after 1 week again 150 by 100. So you are dealing with a case of chronic hypertension. Clear to all of you? Yes? Okay, now when to start antihypertensives? Now according to ACOG, antihypertensives should be started when BP is more than 160 by 110 on 2 occasions 15 minutes apart. So if you are getting 160 by 110 BP and there you are getting 2 readings just 15 minutes, you don't have to wait for 4 hours, you just took after 15 minutes you took another reading and again it is more than 160 by 110, then that's an indication to start antihypertensive therapy. This is what is called as hypertensive crisis, when BP becomes more than 160 by 110 and the drug of choice is IV labetalol. Practically, we are going to start antihypertensive when you are getting BP more than equal to 150 by 100 on 2 occasions 4 hours apart. Right? And in this case, I am going to start with oral labetalol. Right? Please remember that the drug of choice, the antihypertensive of choice for PIH is labetalol. For hypertensive crisis, again it's labetalol, that is IV labetalol. Drug of choice for chronic hypertension in pregnancy, that is alpha methyl dopa. Alpha methyl dopa is the safest antihypertensive in pregnancy. Right? Okay. Coming to question 12. All of the following indicate HELP syndrome except option A, unexplained anemia, option B, decreased LDH, option C, low platelet count, option D, raised liver enzymes. Tell me, all of the following indicate HELP syndrome except? I'm waiting for your answers. Option A, unexplained anemia. Option B, increased liver enzymes. Yes, if single reading is more than 160 by 110, you can start medical management, but Generally, we do not start it based on just a single reading. There is this white coat hypertension. So by single reading, we mean that just you wait for 15 minutes and you take another reading. So I can see most of you answering this question as B. Most of you are answering it as B, and that's right. So what is the criteria for HELP syndrome? The criteria for HELP syndrome is Tennessee's criteria. And according to Tennessee's criteria, you should have evidence of hemolysis. H stands for hemolysis, EL for elevated liver enzymes, and LP for low platelet count. So all these three things should be satisfied. There should be evidence of hemolysis, elevated liver enzymes, and low platelet count to call it as HELP syndrome. Now, in evidence of hemolysis, any two of the following four should be present. What are those two? Number one, serum bilirubin more than equal to 1.2. Number two, decreased haptoglobin levels or increased LDH levels. Number three, on peripheral blood smear if you are getting schistocytes or Burr cells. And number four, if you are getting unexplained severe anemia. Right? So this is your, out of these four, any two if present, they indicate hemolysis. Serum bilirubin more than 1.2, decreased haptoglobin, increased LDH level, peripheral blood smear showing you schistocytes or Burr cells, and unexplained severe anemia. Elevated liver enzymes means to more than 2 times their normal values, and low platelet count how much? Less than 1 lakh. So this is your Tennessee's criteria for diagnosing HELP syndrome. So over here, unexplained anemia, yes, not decreased LDH, increased LDH, it is decreased haptoglobin and increased LDH, low platelet count and raised liver enzymes. Now, what is the most common time for development of HELP syndrome? Most common time is 3rd trimester. What is the most common presentation of HELP syndrome? It is epigastric pain. Please remember, in HELP syndrome, BP of the patient is high. But in 20% cases, BP is normal, right? And that is every time I have repeated this and I have told you. Recurrence rate for HELP syndrome is 4 to 7%, and HELP syndrome is more common in multigravida females, whereas PIH is more common in primigravida females. And I told you that risk factors for PIH are very, very important. Right? But HELP syndrome is more common in multigravida females. Now, in HELP syndrome, when do you terminate pregnancy? Termination of pregnancy is done at 34 weeks. Mode of delivery is vaginal delivery. Please remember, if HELP syndrome happens at less than 34 weeks, in that case, I am going to give steroids so that the lungs of the fetus mature. Right? And then after 48 hours, I will deliver the patient. Right? So that is how you manage HELP syndrome, that you have to terminate pregnancy at 34 weeks. After 34 weeks, anytime you can terminate. Before 34 weeks, again I have to terminate, but first I'm going to give steroids so that the lungs of the baby mature, and then after 48 hours, I'm going to terminate her pregnancy. Mode of delivery will be vaginal delivery. If patient's BP is high, I'm going to give her antihypertensive, and so that she doesn't throw convulsions, because HELP syndrome patients may get converted into eclampsia, I will give them magnesium sulfate. Right? Overall, in all patients of PIH, the anesthesia of choice is epidural anesthesia. Suppose you have to do a cesarean section, then you have to give epidural anesthesia. Most common complication of HELP syndrome is abruptio placenta. Right? Clear to all of you? So this is what you have to know about HELP syndrome. Please also you should be knowing how to differentiate patients of HELP syndrome, how to differentiate patients of acute fatty liver of pregnancy and of cholestasis. All these three, how you have to differentiate, and hyperemesis gravidarum. How you have to differentiate between them, you should be knowing. You may get a clinical question on any of these. Next question. In a patient of severe preeclampsia, the signs and symptoms which indicate patient will develop eclampsia are: number 1, lower abdominal pain; number 2, headache; number 3, visual disturbances; number 4, oliguria. So option A, all 4 are correct. Option B, 2, 3 and 4 are correct. Option C, 1, 2 and 3 are correct. Option D, 2 and 3 are correct. Answer this now. Very, very simple question. So what are the signs and symptoms of impending eclampsia in a patient of severe preeclampsia? 1, lower abdominal pain. Number 2, headache. Number 3, visual disturbance. Number 4, oliguria. Okay, tell me. So you are saying all 4 are correct. Most of you are saying all 4 are, no, now some of you have started saying 2, 3 and 4. So you are saying option B. So the confusion is between option A and option B. Who is saying? SM is saying, someone is saying option D also. Some of you are saying option D also. Okay. Right. Now, first understand. Now, please tell me that in a patient of eclampsia, you get abdominal pain, but what kind of abdominal pain? Is it lower abdominal pain or is it upper quadrant pain, that is epigastric pain? What are you going to say? In a patient of impending eclampsia, which type of pain do you get? Lower abdominal pain or epigastric pain? It is because of the stretching of liver capsule. So it is epigastric pain which you get in a patient of eclampsia, impending eclampsia. Headache, yes. And what kind of headache? That kind of headache which is not relieved. It is a persistent headache, very severe headache, which is not relieved by the normal medications, right? Then visual disturbances, yes. Oliguria. Now, is oliguria a finding that a patient is about to throw convulsions? Is oliguria a finding that the patient is about to throw convulsions? Is oliguria a sign of impending eclampsia, in other words? Yes or no? Is oliguria a sign of impending eclampsia? हो गया epigastric pain. I know all of you were very confused regarding epigastric pain. So that lower abdominal pain is not seen, and that is why I made you write epigastric pain. Now tell me, is oliguria a sign of impending eclampsia? So again, we have varied answers. Some of you are saying, yes, it is a sign of impending eclampsia. Others are saying it is not a sign of impending eclampsia. Right? Now, please understand, just now I told you that oliguria is a finding which you get in severe preeclampsia. Oliguria is not a criteria for diagnosing severe preeclampsia. Similarly, oliguria is not a criteria for impending eclampsia. Right? The signs and symptoms which tell you that there is going to be impending eclampsia are epigastric pain, headache and visual disturbances. Right? Epigastric pain plus minus nausea, vomiting, headache which can be there with dizziness, and visual disturbances. These are the ones which are specific that yes, impending eclampsia is about to happen. Right? Oliguria again is a finding in eclampsia patient, but it is not that it is a sign of impending eclampsia. Because overall, in case of PIH, the blood flow is reduced to the kidneys. So yes, in a case of PIH, oliguria will be present. But presence of oliguria doesn't mean that it is a sign of impending eclampsia. Right? Clear to all of you? Now, so this means your answer is 2 and 3. These are very small, tiny things which you have to remember. Similarly, remember magnesium sulfate toxicity. Now, is oliguria a sign of magnesium sulfate toxicity? No. Oliguria is not a sign of magnesium sulfate toxicity. Why do we check urine output then when we are giving magnesium sulfate? Because magnesium is excreted through the kidneys. And because magnesium is excreted through the kidneys, that is why I am checking urine output. But if you say that oliguria is a sign of magnesium sulfate toxicity, that's wrong. Clear to all of you? Yes. Now, whenever you have a patient with impending eclampsia, what is the best management? Best management is termination of pregnancy irrespective of the gestational age. Right? But if they ask you what is the next step, that whenever you have a patient of impending eclampsia, next step is magnesium sulfate, that is the best answer, and antihypertensive therapy. Right? If they ask you what is the next step in management of eclampsia, patient of eclampsia has come to you, what is the next step? Next step is airway management. So the first step which you have to do when a patient of eclampsia comes to you is airway management. The first step which you have to do whenever a patient of impending eclampsia is there is magnesium sulfate followed by antihypertensive. Best management of impending eclampsia is termination of pregnancy irrespective of gestational age. Again, best management of eclampsia is also termination of pregnancy irrespective of gestational age. Clear to all of you? Yes, this is airway what I have written. I know my handwriting is very bad. Okay. Coming to question number 14. Question number 14 is a 26-year-old primigravida at 31 weeks of gestation is being evaluated with Doppler ultrasound studies of fetal umbilical artery. Patient is a healthy smoker. Her fetus has shown evidence of Iugr on previous ultrasound. Doppler study currently show that SD ratio is higher than it was in her last ultrasound and there is absent diastolic flow. The next step in management is, now tell me, what is the next step? Patient has come to you at 31 weeks. So the crux of the story is 31 weeks, Iugr is there, and Doppler is showing you absent end diastolic flow. What is the management? Tell me. Option A, immediate induction of labor. Option B, immediate termination of pregnancy by cesarean section. Option C, admit the patient, give steroids, do fetal monitoring and termination at 34 weeks. Option D, admit the patient, give steroids, do fetal monitoring and termination at 32 weeks. Now I can see all of you answering it as C, some of you are answering it as B, but most of you are answering it as C. Quickly, let us do a few concepts on Iugr. What do you mean by Iugr? If the effective birth weight is, the estimated birth weight is less than 10 percentile, or if abdominal circumference is less than 10 percentile, which is appropriate for that gestational age. Now, in this patient, Iugr is there, and what is the reason for her Iugr? This patient is a smoker. And because of smoking, there is uteroplacental insufficiency, and that has led to Iugr. What is the criteria for uteroplacental insufficiency? If at gestational age more than equal to 28 weeks, SD ratio is more than 3. On Doppler, if SD ratio is coming more than equal to 3 and gestational age is more than equal to 28 weeks, then we say that it is uteroplacental insufficiency. So in this case, patient was a smoker, there was Iugr, and when Doppler study was seen, done, SD ratio was increased and now there is absent end diastolic flow. So SD ratio more than equal to 3 at more than equal to 28 weeks means that this patient has developed uteroplacental insufficiency, right? Okay. Now, please understand this is a very, very important table, condition of pregnancy and at what time you have to deliver. In mild preeclampsia, the time of delivery is 37 weeks. In severe preeclampsia, 34 weeks. In eclampsia, immediately you have to deliver. In HELP syndrome, I told you if it is more than 34 weeks, immediately deliver. Less than 34 weeks, then you have to give steroids and terminate pregnancy after 48 hours. In chronic hypertension patient who is well controlled, right? Well controlled chronic hypertension patients, time of delivery is between 37 to 39 weeks, more at 39 weeks, right? But chronic hypertension, which is difficult to control, the termination of pregnancy is done between 34 weeks to 36 weeks plus 6 days, right? Now, when we talk about umbilical artery Doppler, if SD ratio is increased to more than 3, then you are going to deliver the patient at 37 weeks. But if the question says that SD ratio is high and there is oligohydramnios, then you are going to deliver between 34 to 37 weeks, right? SD ratio more than equal to 3, no oligohydramnios, time of delivery 37 weeks, more than equal to 37 weeks. SD ratio high and oligohydramnios, time of delivery will be between 34 to 37 weeks. Absent end diastolic flow, time of delivery 34 weeks. Reversed diastolic flow, time of delivery 32 weeks. Now, please remember that if you are having absent end diastolic flow and patient is not 34 weeks, you have to terminate pregnancy at 34 weeks. Now, over here, patient is 31 weeks. So, in the meanwhile, I'm going to give her corticosteroids, I'm going to do fetal monitoring, I'm going to do a biophysical profile, Doppler and NST, and then I'm going to terminate pregnancy at 34 weeks. Clear? So, over here, because it is absent end diastolic flow, the answer is option C. You have to deliver at 34 weeks, and before that, you will give corticosteroids, do a fetal monitoring, and try to carry the pregnancy up till 34 weeks. Clear to all of you? So the answer is option C. It's not option B. You are not going to go for immediate termination of pregnancy because patient is 31 weeks. In absent end diastolic flow, you have to terminate pregnancy at 32 weeks. In reversed diastolic flow, you have to terminate pregnancy at 32 weeks. In absent, at 34 weeks. In absent end diastolic flow, 34 weeks, reversed 32 weeks. Before that, the management is same, that you have to do regular fetal monitoring. Daily you have to go for a biophysical profile, NST and Doppler, and you have to give corticosteroids and carry the pregnancy up till the respective gestational age at which termination can be done. Right? Now, in diabetes, I also want to talk to you about at what time pregnancy is terminated in diabetic patients. Now, in diabetic patients, whether they are gestational diabetes or overt diabetes, if it is a well-controlled diabetes could be on diet alone, it could be on insulin, it could be on metformin. If it is well-controlled diabetes, any kind of diabetes which is well-controlled, gestational ho, ya overt हो, insulin पे well controlled हो, diet पे well controlled हो या metformin पे well controlled हो, the termination of pregnancy has to be done at 39 weeks, not before that. And if diabetes is not well controlled, whether it is gestational or whether it is overt, then it has to be done between 37 weeks to 38 weeks plus 6 days. Right? Remember, gestational diabetic patient controlled on diet, that is A1 diabetes. Gestational diabetic patient controlled either on insulin or metformin is A2 diabetes. So this is Priscilla-White classification. According to Priscilla's White classification, gestational diabetes is type A diabetes, and if gestational diabetes is controlled on diet, it is A1. If gestational diabetes is controlled on insulin or on oral hypoglycemic agents, it is A2. Right? Overt diabetes are non-A type of diabetes according to Priscilla-White classification. Clear to all of you? Yes? Okay. Now, Question number 15, and this is the last question for the day. I will be talking about Rh negative pregnancy in the next session, right? Now, a G2P1 female with previous history of preterm labor complains of pain in abdomen at 34 weeks of pregnancy. She is having 3 contractions in 10 minutes. Her sterile per speculum examination shows membranes are intact. On per vaginal examination, cervix is 3 centimeters dilated, 30% effaced. Management includes number 1, nifedipine, number 2, dexa, number 3, magnesium sulfate, and number 4, induction of labor. So option A 1, 2, 4, option B 2 and 4, option C 2 only, option D 4 only. Tell me. It is about to end. The session is about to end. This is the last question. Now, in the previous session, the first session which we had on bleeding in pregnancy, I told you that for preterm labor diagnosis, you need uterine contractions plus on per vaginal examination, cervix should be dilated. How many contractions? More than equal to 4 contractions in 20 minutes or more than equal to 8 contractions in 60 minutes. Right? So, if patient is having contractions and on per vaginal examination cervix is dilated to more than equal to 3 centimeters, then we say that the patient is a diagnosed case of preterm labor. Or on ultrasound, the length of the cervix is less than 2 centimeters, then we say she is a diagnosed case of preterm labor. Now, if on ultrasound cervix length is between 2 to 3 centimeters, then fetal fibronectin protein should be present to say that she is a diagnosed case of preterm labor. So, with uterine contractions, if you are getting any of these 3, then you say it is a diagnosed case of preterm labor. So, over here you are getting 3 contractions in 10 minutes. So, definitely there will be more than 4 contractions in 20 minutes, right? So, contractions are present. And on per vaginal examination, cervix is 3 centimeters dilated. So, when it is more than equal to 3 centimeters dilated, you say it is a diagnosed case of established preterm labor. This is a case of established preterm labor. Patient has come to you at 34 weeks with established preterm labor. Now, what are the things which you can use in preterm labor? Number 1, you can use corticosteroids in preterm labor. Why you use corticosteroids? For lung maturity. The corticosteroid of choice in India is dexamethasone, which you have to give 6 milligrams, 4 injections, 12 hourly. Right? Worldwide, it's betamethasone. In India, it's dexamethasone. Now, corticosteroids are given in all cases of preterm labor up till 36 weeks plus 6 days. Earlier, it was said that corticosteroids are given only up till 34 weeks. Now, they say it is given up till 36 weeks plus 6 days. So, in all cases of preterm labor, you have to give corticosteroids. Magnesium sulfate. What is magnesium sulfate used for? It is used for neuroprotection. And it is used in all preterm labor which are happening at less than 32 weeks. Tocolytics. Tocolytics are used in all preterm labors when preterm labor is happening at less than 34 weeks. So, when preterm labor is happening at less than 34 weeks, then you use tocolytics. The tocolytic of choice in India is nifedipine. That is the safest tocolytic. But sometimes they ask you which is the tocolytic of choice at less than 32 weeks. Now, if your question specifically asks you at less than 32 weeks, that means they are talking about endomethacin. Endomethacin is also a tocolytic, but it is used only at less than 32 weeks. You cannot use endomethacin beyond 32 weeks. Why? Because if you use endomethacin beyond 32 weeks, then it leads to closure, premature closure of ductus arteriosus, and it can also lead to oligohydramnios, right? Now, between 32 to 34 weeks, the only choice which we have is nifedipine. Less than 32 weeks pe you can use endomethacin, you can use nifedipine. Between 32 to 34 weeks, you have to use only nifedipine. So, tocolytic of choice always is nifedipine. A blanket question, tocolytic of choice is nifedipine. Safest tocolytic, nifedipine. Please remember that whenever you are using tocolytic, you have to use them only for short duration so that the corticosteroids act. And corticosteroids can act within 48 hours of giving the last injection. So, please remember you are going to give tocolytics maximum for 48 hours or 48 to 72 hours, not beyond that. So, beyond 72 hours, you never use tocolytics. Generally, you use it only for 48 hours, right? Now, so nifedipine, this patient is coming to you at 34 weeks. Tocolytics are used at less than 34 weeks. So are you going to use nifedipine? No. Dexamethasone? Yes. Magnesium sulfate? No. It has to be used in preterm labors at less than 32 weeks. Induction of labor. Please remember that in preterm labor, which is happening beyond 34 weeks, you will not use tocolytics, but then you will also not go for induction of labor. If premature rupture of membrane is happening at more than 34 weeks, then you go for induction of labor. In preterm labor, we do not go for induction of labor. In premature rupture of membranes, we go for induction of labor. So the answer is option 4 only. D, that is 4 only. Right? Answer is not, sorry. It's 2 only. 2 only. It's not 4 only, it's 2 only. So the answer is only 2, that is only dexamethasone. So the answer is option C. Right? It's only dexamethasone which you are going to use at 34 weeks. Nifedipine tocolytic has to be used at less than 34 weeks. Magnesium sulfate has to be used at less than 32 weeks. Induction of labor is not done in preterm labor unless and until membranes are ruptured. If membranes are ruptured beyond 34 weeks, then you go for induction of labor. In preterm labor, you do not go for induction of labor. Right? So answer is option C, that is 2 only. Clear to all of you? Yes? So I hope you found this discussion useful. One topic, that is Rh negative, I am going to take with the next discussion which we are going to have on next Monday. In the meanwhile, keep practicing MCQs, and if you are liking these sessions, please like the session and subscribe to the channel also so that you get all the notifications. And my Instagram handle is Dr. Sakshi Arora Hans, Obs and Gynae. Right? Why not 4? Induction of labor, that's what I'm telling you. Induction of labor is not done in preterm labor. In preterm labor, you give corticosteroids, and whenever labor happens, you just wait for spontaneous labor to happen. You do not go for induction of labor. In premature rupture of membranes, because there is a fear of chorioamnionitis, that is why in premature rupture of membranes, you go for induction of labor, not in preterm labor with membranes intact. Okay?